Okay, so we are doing module 3 on heart failure. And we're going to start with case study number 1. This is from your Harding Clinical Case Studies book. You guys should all have a online copy of this book, and it's my favorite. I know students don't like it so much because it doesn't come with answers, but the case studies in it are really awesome. So I try to do some in class, that way we have an opportunity to work through them. So here we go. We got 2 case studies to go through tonight. So MG is a frequent flyer. Do you guys know what frequent flyers are? It's kind of like the airlines, but for hospitals. So yeah, somebody coming in a lot to the hospital. So she comes into the ER with a diagnosis of heart failure. She's discharged from the hospital 10 days ago and comes in today stating, "I just had to come to the hospital today because I can't catch my breath and my legs are as big as tree trunks." After further questioning, you learn she is strictly following the fluid and salt restriction ordered during her last hospital admission. She reports gaining 1 to 2 pounds every day since her discharge. So she's potentially gained how much weight since her discharge? Yeah, 10 to 20 pounds over 10 days. That's like, can you imagine gaining that much weight in that short amount of time? That's crazy. And she's like, just like, now she's reached her, like, her tipping point, 20 pounds in. Okay, so with that, what error in discharge teaching most likely occurred? What do you guys think? Where did we go wrong? Waiting too long, for sure. And she says that she was following it strictly. No, she said that she was, if you go back, she said that she's been following her fluid and salt restriction like she should, strictly. Maybe she doesn't know what that means. It's entirely possible, but she says she's been being good. Maybe she didn't understand, but yeah, maybe she hasn't been doing her daily weights. Yeah, but basically she doesn't know when to call. Because we don't want her to call when she's, we don't want her to call when she's gained 20 pounds in 10 days, right? We want her to call when she starts like tipping the scales at 2 pounds, right? Or is it 5 pounds away from goal weight and 2 pounds in a day or something like that? There's rules. We'll cover them in the end here. I always get it confused, but it's way before gaining 20 pounds, right? She needs to call her doctor. Here you go. 2 pounds in a day. So if on day 1, if she gained 2 pounds, then she should already have been on the phone. But certainly at the 5-pound mark, within that first week, and then she's waited beyond that up to 10 days. Okay, so we did an echo. It revealed that her ejection fraction is 30%. What is a normal ejection fraction? Because we throw out 30% and you're just like, meh, meh, meh. Yeah, so we want it to be above 50, right? So hers is 30, but a month ago it was 40. So is she getting better or worse? Yeah, so what is EF? What is that number talking about? You don't have to get super technical, but basically what's happening. Yeah, so how much blood is leaving the ventricle, right? So she is supposed to be greater than 50%. She was at 40%, but now she's at 30%. Could you see how this could have significant impact on like her whole ability to function? She's like 20% less than what she should be as far as like how much blood is getting to the rest of her body. So significant impact at this point, okay? Significant heart failure. So what kind of presentation would she have if she had a ejection fraction of 30%? What do you guys think? Like, what are some issues she might have? How would you feel? Right. Maybe some activity intolerance? Mm-hmm. Yeah, for sure. Okay, so your homework is to go look at 30% ejection fraction and find out what stage of heart failure that is and what your activity limitations will be. Okay, so yeah, she's getting worse. And it just means she's getting less perfusion to her body, right? And things aren't going to work right. Okay, so during the admission interview, the nurse makes a list of the medications she takes at home. So she takes enalapril. What's enalapril for? Mm-hmm. It's hypertension med, right? What about, I don't know how to say that, the glitazone, the pioglitazone? What kind of medication is that for? I did really well in nursing school, but I got a C in pharmacology. That was like the only class I got a C in. Fun fact about Professor Hughes. Yeah, it's for diabetes. Okay, so she's got a diabetes med, and she takes furosemide, and then she takes some potassium. Why does she take the potassium? Yeah, because of the diuretic, right? So she doesn't get hypokalemic from the Lasix. Okay. How do angiotensin converting enzyme inhibitors, ACE inhibitors, such as enalapril, work to reduce heart failure? Select all that apply. What do you guys think? You're like, wait, I didn't know I had to know this. Anybody know? Any guesses? So A, yes, we dilate. Yeah. So if we dilate, what does that do? That will give you the next answer. Correct. C, right? We reduce the preload and the afterload. And D, right. Prevent the conversion of angiotensin 1 to angiotensin 2. So angiotensin converting enzyme inhibitor, right? It gives it away in the name if you can remember all of those words. So yeah, that's what they do. And that's why you give them to people with heart failure, because they do those things. So after reviewing her medications, the cardiologist writes the following medication orders. Oh, sorry, I forgot one thing. So that diabetes med that she's on, the glitazone one, you're not supposed to give it to heart failure people. It can actually make heart failure worse. So, or it increases the risk of heart failure. So they should never have given it to her because of the fact that she's got some heart failure. I think that class of medications, I'm not sure specific, I would guess it's the class, um, but I know specifically that one. So that would not be a heart failure appropriate medication for diabetes. So you'll see here that they're going to change her order. Okay, after reviewing her meds, the cardiologist writes the following medication orders. So she's still on that enalapril. They added carvedilol. What's carvedilol? What kind of medication is it? Yeah, it's a beta blocker, which we definitely give to heart failure patients. Metformin, so they switched that out for her diabetes meds, and then she's got the furosemide. Now we're giving her 80 milligrams instead of 40 milligrams, and we're giving it IV push. Why would we give her IV Lasix? Mhm. So it acts fast, right? So PO med versus an IV med, IV is going to work quicker. Yeah. And she's gained like 10 to 20 pounds, and she's got tree trunk legs, and she can't breathe. So we need to get the fluid off like, you know, 8 days ago. um, so we needed to act quickly to get her better because all of that excess fluid is just trashing her heart even more, right? So we give that Lasix. What are 4 parameters that we would use to tell if our Lasix is working? So how do we know that our Lasix is doing any good? Yes, eyes and nose, she'd be losing weight for sure. Urine output would go up. What else? How about how feeling better, Carrot, specifically? So what was she complaining of? Labs. So what labs too? We can check her blood pressure. Yeah, shortness of breath would be better, correct? And then what else? What else did she have that brought her in? Do you remember? Edema, yeah. So we would want that edema to get better, right? So yeah, we would check urine output. She would tell us that her breathing was better. We could listen to lung sounds. We could see if she was still hypertensive. We could check her edema. We could check her lab levels and see what her BNP level is, right? Because that's what we use to tell about heart failure. So yes, oxygenation levels. How's her O2 sat? Did I say lung sounds? We would want to listen to her lung sounds. If she's got, so it sounds like she's got what type of heart failure does she have? Ah, yes. So she's got both, right? So why does she have both? So left-sided is what? Why do we think she's got left-sided? You're good, Garrett. This is why we do this, right? So we can all get on the same page. Shortness of breath, right? She can't breathe. So that's left-sided. Now, why do we say right-sided? Edema in the body. Because she's got both. Where was I going with that? I don't remember. Anyways, but yeah, she's got left-sided and right-sided heart failure. Oh, we would want to check for signs of right-sided heart failure besides edema. So what's another thing that you can just like look at a person and see that they have if they've got right-sided heart failure? Yeah, so see if she's got any JVD, right? That'd be to assess for. There's another thing that people will get. What happens to their abdomen? They can get ascites. So see if they've got a swollen belly. Okay. Okay, yeah, so we already talked about with Lasix. What labs are we going to take? Yeah, BNP, potassium. Yep, you want sodium too. So what you would order is a CMP, complete metabolic panel, right? Because that's going to give you all your electrolytes. It's going to tell you about your kidney function. You're going to want to throw a BNP in there as well. Not so much the CBC, right? F. Not so much the coagulation studies. Those are kind of different. But everything else you'd want to check for. So why did they order the beta blocker? So why do people with heart failure get beta blocker? That was not good English. Why do you need a beta blocker? It slows it down, keeps it from overworking, right? It's going to bring that pulse rate down. So reducing cardiac stimulation from catecholamines, right? D, yes. It's going to make it not work so hard because what your heart wants to do is it wants to speed up to help increase cardiac output, right? But what happens when it speeds up? Heart rate raises, yeah, but it just puts more workload on the heart, right? Correct. And it's already not working very well. So you're just stressing it out more. So make sure you understand you'll have, I think, at least 2 questions on your test about this. The impact of the body's compensatory mechanisms on the worsening of heart failure and what medications we give to help counteract those compensatory mechanisms, because they only compensate for so long and then they make the problem worse. Okay, so make sure you spend some time reading that, understanding it, getting it in your head, because you will be tested on it and it's important for you to know. That way, when you're giving education to your patients about why they need to be compliant with their meds, you know what to tell them, right? Like, these things are actually helping your heart not get more sick. Okay. Moving on. 1 day later, MG has shown only slight improvement and digoxin is added to her orders. What does digoxin do? A, B, C, or D? This is a nice little medication review. I like this one. Anybody know? There we go. Yeah, makes your beats stronger, right? So yeah, that's why they're giving her that, to make the beats that she does get like more beefy, right? What would increase a patient's risk of digoxin toxicity? Have y'all learned about dig in pharmacology yet? Oh, good. I see a K. What about K? Not hyper. Hypo. Yeah, so if you've got low potassium, good guess, Alice. I like guesses. I like people that just try. Just throw it out there. If you're wrong, it doesn't matter. We'll figure it out. Hypokalemia increases your risk of digoxin toxicity. So why is that a problem for our friend? What medicine is she on that could make that a thing? Lasix, right? Furosemide can cause hypokalemia. So do we think we need to monitor the potassium level very closely for our friend? Yes. Is this a problem for heart failure patients? Yes. Because do they need to be on DIG? Yes. Do they need to be on Lasix? Yes. So do we have to give them extra potassium? Yes. So it's this whole dance. So you'll have daily labs on these folks. And if you're giving them tons and tons of Lasix, then you're going to have to really watch that closely, okay? Because it can be a whole thing. Because you don't want to invent a new problem by giving them DIG toxicity. So her symptoms improve with the diuretics and DIG. She's placed back on her oral Lasix once her weight loss is deemed adequate for achievement of an euvolemic, I don't know, euvolemic state? How do you say that? Equal. So she's like, she doesn't have any extra, she's not dehydrated, she's just where she needs to be. What will determine whether the oral dose will be adequate for discharge to be considered? So how do we know that she's good on her oral dose of Lasix? Right, so she doesn't get worse again, right? Yeah, so all the things that were broken before, they don't come back. Yeah, so she's not symptomatic. Her weight is okay. Her labs look okay. Like, yeah, all the things that were out of whack before don't become out of whack again. It's a very technical term. Okay, discharge teaching. As I said in the lecture, did you guys get a chance to watch that, listen to that? Did it make sense? The thing I posted on Monday, I guess. Okay, good. So you have to know about discharge teaching, because the whole point is trying to keep these people well, and you have to manage them very closely, because it's this whole balancing act between, not having excess fluid but not dehydrating them. And there's lots of like things that have to be managed to keep them well. Okay, so discharge teaching is so important for your heart failure patients. So make sure that you understand discharge teaching. And this is a cool little illustration that I came across. MODS. So any guesses on what medications mean? Or I just gave it to you. M is medications, okay? So whatever medicines that they have ordered, they need to take them. Don't skip them. Don't run out. What do we think A stands for? Activity. You need to get moving, but don't try to go run a marathon, right? Don't join CrossFit. Start small. Go for a walk. Do some water aerobics, right? What about W? Weight, right? So 2 pounds in a day, 5 pounds in a week, or whatever parameters your provider gives you. If you start gaining weight, that's not ideal. And then how do they weigh themselves? Because like if you weighed yourself at like in the morning and then you weighed yourself in the afternoon, you weighed yourself at night. Yeah, same time, same scale, and then there's the same clothes, right? Or lack thereof. So yeah, make sure you're doing it the same way, right? That way you get an adequate measurement. Yes, so when they're gaining weight, but yeah, I think that's what the parameter is 2 pounds in a day and 5 pounds in a week. Um, or 5 pounds from target weight is another thing. It's just whatever their provider gives them. You're not going to have a question on your exam that's like, when should your patient call the doctor? When they've gained 2.5 pounds in 3 days, or B, 15 pounds in 7.5 days? No, you're not going to have any test questions like that, but they'll get very, we wouldn't give you anything that easy. It would be like, if a African swallow is southbound on, you come up with what color is your neighbor's jacket, right? That would be the question we would give you. Yeah, we invent all sorts of crazy things. Where were we? D. D is what? You guys have already kind of told me that one. So what is the diet? Low sodium and what else? Yes, low fat. What else? Fluid restriction. Talk to me about fluid restriction. Yes, please don't do fast food. Do you know, quick story. So when I was in nursing school, I did a rotation through a high school, working with the school nurse. And there was a kid in there who was 17 years old. He was a football player, and he had hypertension. Like, I think his blood pressure was like 150 something systolic, and he's like 17 years old. Okay. So, was asking him about his diet. For a snack after school, he went and got a Wendy's spicy chicken sandwich with fries and a Coke. And that was just a snack after school. Okay. That wasn't including whatever he got in the cafeteria that day, whatever he had for breakfast, whatever he had for dinner. Okay. So go look up the nutritional information for a Wendy's spicy chicken sandwich and a large fry with a Coke, and tell me how much sodium is in that dream of a combo. The kid was just drowning himself in salt, and that was what he had after school every day before football practice, at the encouragement of his coach, who wanted him to gain weight. Holy cow, it was a whole thing. I'm like, dude, if you are already hypertensive at 17, bless it. Okay, and then S. S stands for symptoms. So what to report, when to call, that kind of thing, because you don't want to wait till you've gained 20 pounds, right? Yes, C, yeah. That's like a quarter of your daily allowance, right? Yeah, obnoxious. See? Yeah, that's just one meal. Redunculous. And then he's like 17. He's like, I don't care. I just want to eat my spicy chicken sandwich. Okay. It's very difficult to teach 17-year-olds. I know. No, he didn't stop. I mean, I saw him like one day. But yeah, it's just super sucky that he drew like the genetic lottery to have stupid blood pressure. Okay, so after our teaching session, the nurse asks MG to teach back one important concept of care at home. Which statement by MG indicates a need for further education? Explain your answer. Right, yeah. That was the problem, right? That's probably why she gained 20 pounds, or 10 to 20, right? Yeah, so C, the time frame is wrong. After MG's been home for 2 days, the heart failure nurse navigator calls to ask about her progress. She reports that her weight has not increased since she's been home and she is breathing more easily. Hooray! We fixed her. Okay, let's go to the next one. New patient. So we have Miss C, an 81-year-old client to the ICU. She has a history of mitral valve regurgitation. So if you remember, risk factors for heart failure is valve issues, right? So mitral valve regurgitation, so she's got some leakage back out of that mitral valve, and it can cause heart failure. So she's got left ventricular failure. She came into the ER with symptoms of increasing shortness of breath over the past week. She's getting Lasix IV in the ER, and she's got 4 liters nasal cannula. Is that very much oxygen for an ICU level patient? Not really. Okay. Yeah, usually they got more than that. Okay, so she arrives to your ICU. She's sitting up in bed at 60 degrees. She is pale with circummoral cyanosis and her respirations appear labored and rapid. She indicates she feels short of breath. So is your patient doing well? So this is when you call and chew out the ER. She was fine when she left me, is what they will say, because I was an ER nurse. She was breathing just fine. So if your patient shows up like this, what are you going to do first? I think you could do one of two things. Yeah, so you guys realize that listening to breath sounds and asking about dyspnea are probably not ideal, right? Because the thing that they're not doing is fixing the situation, right? So I could appreciate somebody saying, go ahead and sit her up a little bit more as the thing to do first. I would sit her up while I'm putting the O2 sat monitor on her. So I would do that kind of simultaneously. The book said that the answer is C, but I think you could do those two things concurrently, and that would be fine. So when you assess her, she's got audible crackles throughout both lung fields. She's coughing up pink frothy sputum. Remember, that's like textbook for heart failure patients, right? Her O2 sat is 85% with the O2 at 4 liters per minute nasal cannula. Her respiratory rate is 38 breaths per minute, and she has 3 to 4 pitting edema in her feet and up to mid-calf. With the head of the bed elevated to 75-degree angle, the jugular veins are distended up the jawline. Is your patient very stable? She got a lot going on, doesn't she? Poor thing. All right. Based on the client's history and assessment, the nurse will be most concerned about which complication. What do we think her primary problem is here? She's got circummoral cyanosis, so she's blue around her lips. She's got a SAT of 85%. She's got uh, audible breath sounds, right? Yeah, so pulmonary edema. So that's what your left-sided heart failure patients are at risk for, is pulmonary edema, and it's life-threatening, remember? So we will definitely be asking you questions about it, because your patient can die from it, because they're like drowning in their own fluid, which just sounds terrible. No, pulmonary edema comes with left-sided heart failure. Right-sided heart failure affects the rest of the body, not the lungs. Correct, left of lung. Peripheral edema is right. Yes, she has both. So she doesn't just have left-sided, she's got right-sided heart failure because she's got that edema that goes up to mid-calf, right? So we've got a biventricular issue here. Yeah. But the complication that we're worried most about, so edema like is uncomfortable, but it won't kill you, right? It's the pulmonary edema that will kill you. So that's the complication that we're most worried about. Does that make sense? Yeah, so important distinction for you guys to realize. So that's why we focus so much specifically on the complication of pulmonary edema and not on things like ascites. It's, uncomfortable again, and it can have complications associated with it, but not as quickly as your pulmonary edema. So what are we going to do first? What is the thing that we can do to help fix her right this second? Improve her situation right now? Yeah, we need to give her some more oxygen, right? She's on 85%. She's got nasty breath sounds. She's got blue lips. We need to increase that oxygen because 4 liters nasal cannula is nothing. It's a drop in the bucket. Okay. And we need to help improve her her breathing status like right now. Then you could call your rapid response and those sorts of things. What is another additional assessment that we want to get at this time? So would that be the same for the following from the study guide? Yes. But make sure you get all your details, okay? We quickly have grazed over this, but make sure you flesh that out a little bit more, Tori, okay? Okay, so this question is tricky. When you answer a question like this, I want you to think about the ABCs, okay? Airway, breathing, circulation. And this is going to come up repeatedly through this class. We're going to add on the letter D for disability, which is another way to say neuro changes. And so when you're thinking priorities, you think of ABCs in that order, okay? And you could say skin color and cap refill, but actually what we want to know is D. Yes, because that's going to tell us about perfusion, okay? It's going to give us a little bit more information than skin color and cap refill. Does that make sense? Am I hypertensive? Am I hypotensive? If I'm hypotensive, then everything kind of breaks, right? If I've got a really low pulse versus a really high pulse, both are problematic as far as perfusing everything else. So D would be neuro, and it would come next. Okay, so I would do my blood pressure, apical pulse, skin color, cap refill, and then I would do my neuro. My heart sounds, I would do that probably last. All those assessment things, you would assess for later. But we need to get some more information, and the rest of the vital signs are what we need at this point. Are y'all tracking? Everybody good? Know we got that? Okay. So her potassium level is 3.3. She's got an order for potassium IV. How do we give potassium IV? Do y'all know? Have you learned about IV stuff and skills yet? Thank you, Paige. Yes, slow. We do not push it. What happens if you push potassium? It would burn, yes, but yes, minor death. You would die. Yeah. Yeah, it can cause cardiac arrest. So you never, 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 never give IV push potassium, especially over 1 to 10 minutes, because all of those things would cause death. So you want to give potassium no faster than 10 milliequivalents over an hour in a peripheral IV, or you can give 20 milliequivalents an hour if you've got a central line. But yeah, usually 10 milligrams or 10 milliequivalents over an hour is how we do that. So that is B. It's just an important thing for you to, just by the way, you need to know how fast to give potassium. After you give the KCL, the nurse administers furosemide. Which nursing action will be the most useful in evaluating whether the furosemide is having the desired effect? So why are we giving the Lasix? How are we going to know it's working? So remember the presentation of your patient. What was her problem when she came in? Because this is going to help you know which answer it is. She couldn't breathe, right? So the main way we're going to know if the Lasix is doing what we want it to do is that she can breathe, right? Is that pulmonary edema that we were worried about. So when you're thinking priorities, think, okay, what was my worst case scenario? And how do I know that I'm getting away from that worst case scenario, right? Yeah, so we want her breathing to improve. We would do daily weights, we would measure urine output, we would monitor her blood pressure, but it's the lung sounds that we were most worried about because our patient wasn't getting oxygenated appropriately, correct? Sweet. That's why case studies are so awesome. Everybody's like, case studies, I hate them. But no, like they're really good. They make you think. Puts it in context, right? So you're not just like memorizing random things. All right, so she's got better. Her weight has decreased 4 kilos. A systolic murmur is audible. She denies shortness of breath, has crackles only in the bases. Cardiac monitor shows sinus rhythm and frequent PVCs. She reports no dizziness, but says that her vision seems fuzzy. She has 2+ pitting ankle edema. Her vital signs are better. She's prescribed the following medications: furosemide, aspirin, potassium, enalapril, digoxin. So, sorry, I'm jumping screens here. What of those assessment findings are we going to report to our healthcare provider? Now, don't get confused on this. Think of where she was and where she's at now, and think of what maybe is a new thing. Yeah, so B is not something that she had before, right? So ankle edema is actually an improvement, right? Because she had it up to mid-calf. We knew that she had crackles, but her crackles are better and her O2 sat is better. She did have that apical murmur thing happening. So all of those things are things that have improved with her. They might not be back to complete normal, but they're all better. Those PVCs and fuzzy vision are the thing that we're worried about. What medication did we put her on that could be causing that? So let's look back at these medications at the bottom. Which one of those can have toxicity associated with it? Oh, that digoxin. It works so well, but it can also have toxicity. Do you need to know about dig toxicity? Yes, for the love, please know about dig toxicity. Anything that's got like a toxicity or like a complication like Lasix, or beta blockers, you can make your heart rate go too low, like all those things you need to know, right? Like nitro, you want to watch their blood pressure because you can bottom their pressure out. All the medication, like specific things like that, you need to make sure that you understand. Okay, what lab values would be most important for the nurse to review? What do you think? Yeah, so we want to know what our electrolytes are, right? We want to know D because that tells us about the degree of heart failure. I would say also G because if you have poor cardiac output, what does creatinine tell us? Yeah, creatinine tells us about renal function, right? So if your creatinine, if your BUN and creatinine are affected, that means your kidneys are affected. So we don't have good cardiac output and our kidneys are struggling if those numbers are elevated as well. Okay, so that would be something that we'd want to keep an eye on because your kidneys get kind of dragged along for this adventure. Poor kidneys. We're going to talk about them next week. These are her labs. Okay, so yeah. And then what else? Yeah, the potassium's a little low. BNP is high. We expected that though, right? Because she's got heart failure. Oh. She's got her scheduled meds at 9. Based on her assessment data and lab results, which meds will the nurse hold until after consulting with the healthcare provider? Select all that apply. What do we think? Yeah, so furosemide, right? And then remember that digoxin? What puts you at risk for dig toxicity? Yeah, hypokalemia. So we would hold the Lasix, right? Because that can make you have hypokalemia. And we would hold the dig because if you have hypokalemia, it could make you have digoxin toxicity. Goodness. All right, final slide. Missy is discharged 2 days later with the following meds. Which information will the nurse include when developing the discharge teaching plan? Select all that apply. Do we like daily weights? Yeah, we like daily weights. What about short of breath or have weight gain? Yeah, we want to know that, right? Furosemide in the evening, is that a good idea? No. What about 2,500 mils of fluid a day? That's too much, right? It's usually 2 liters. Sometimes you get more strict, like 1.5, depending on which the degree of your heart failure is. So don't forget about this. There's a question on this. 2 liters or less, usually fluid restriction, okay? Move slowly when changing from lying to standing. Do we like that idea? You're all right, don't worry. Yeah, moving slowly is a good idea. Follow up appointments soon after discharge. Yes, she needs to go to the doctor. And then what about G? Adding salt, cooking with salt. Although not using salt is just sadness. Yes, you could have hypotension. Orthostatic hypotension for sure. All right, friends, those are our case studies. Hopefully they were, yeah, you could use salt substitute. Hopefully that was educationally valuable for you guys. You are welcome. I always feel like it goes so fast. But make sure you're doing all the things, use all your resources. Reach out to me if you have any questions and I can help. Otherwise,
Yes.
yes.
So I was looking at ATI because